Angelman syndrome is a rare syndrome that occurs throughout the world in all ethnic groups. Although the exact prevalence is unknown, it is estimated that Angelman syndrome occurs in 1 in every 1,500 live births. This syndrome was discovered in 1965 by Dr. Harry Angelman. The discovery occurred when Dr. Angelman noticed something different about 3 of his patients, recognizing that they all shared similar characteristics. These characteristics included excessive laughing, developmental delay, an extremely limited vocabulary, walking, balance, and difficulty, and seizures. Through further research and genetic testing, Dr. Angelman and his colleagues have been able to pinpoint the exact genetic mutations that result in this syndrome. So what exactly is Angelman syndrome? It is the result of abnormalities, either the deletion or duplication, that occurs in the 15th chromosome. There are many variations of how this mutation can take place. The most common variation is the deletion of the genetic maternal material on the 15th chromosome. However, Angelman syndrome can also result in the duplication of paternal material on the 15th chromosome. The gene is known as UBE3A, where these deletions or duplications occur, and this was isolated in 1997. Now, genetic testing can be used to diagnose Angelman syndrome. This genetic abnormality results in the common misdiagnosis of cerebral palsy or autism. The very first warning signs of Angelman syndrome start right after birth. After a normal pregnancy, a child with Angelman syndrome typically weighs about 200 grams less than his or her siblings. This weight becomes a problem when there are difficulties establishing breastfeeding. Also, the infant seems to have problems gaining weight. Sucking looks like it's occurring for an extended amount of time, but little weight is gained. As the infant ages, he or she starts to display characteristics such as developmental delay, reaching a ceiling of up to 300 months, resulting in severe or profound mental retardation. They also display hyperactivity, a lack of speech, which most people can speak about 1 to 4 words, but a few people with Angelman syndrome can speak up to 60 words. There is typically a walking or balance disorder, where people will have a stiff or jerky gait. Also, typically anyone with Angelman syndrome has abnormal EEG results. The most distinguishing characteristic that I have found, however, is excessive laughter. This is one of the first characteristics that can be recognized as Angelman syndrome. Starting at about 1 to 3 months of age, infants will start displaying excessive social smiling, with little cooing. Later, this smiling will develop into excessive laughter. The reason why this occurs is still being researched. However, it has been determined that the laughter is controllable and is always provoked after a physical or mental stimulus, even if the stimulus is very small. Along with shared developmental characteristics, people with Angelman syndrome have a few physical similarities as well. Angelman syndrome can result in a relatively wide mouth and a protruding tongue. This can also be accompanied by a prominent chin and a small forehead circumference. However, typically people with Angelman syndrome have normal facial characteristics that are similar to their family members. Facial features are not the distinguishing feature in Angelman syndrome. So what does this mean to teachers and interventionists? Due to the lack of verbal communication skills, most children experience exceptional behavior problems such as aggressive biting until a proper method of communication can be developed. Intervention should start as early as possible to start working on these communication skills. American Sign Language can be used, but enhanced natural gestures is the most practical route. Enhanced natural gestures accommodates for the lower cognitive abilities of people with Angelman syndrome, and it also allows others who are not familiar with American Sign Language to communicate effectively. When a child with Angelman syndrome enters the school system, the teacher should work closely with a speech and language pathologist to continue developing communication skills. A skill like turn taking can be incorporated into the everyday curriculum, and peers can be encouraged to foster this skill. In addition to a speech and language pathology, an occupational therapist and a physical therapist will most likely be involved in this child's life. Coordinating those therapies into an IFSP or an IEP is critical, as with any other disorder or syndrome. There will be a need to help with positioning and walking, and the entire team needs to work on providing care that results in a higher quality of life. There has never been a case in which a person with Angelman syndrome was able to live independently. However, self-help skills can be focused on to achieve some independence. Targeted skills are individualized, but typically include being able to feed themselves, dressing, and toileting skills. We want to include all children as much as possible into the general education classroom, but it typically, most of the time, is spent in a room that allows teachers to provide these self-help skills. All caregivers should know that most people with Angelman syndrome enjoy water, reflections, and noises. Keep this in mind when you're designing your curriculum.